Good afternoon and welcome to Icon Cancer Centre's Facebook Live on prostate cancer, in particularly focusing on prostate cancer and COVID-19. Very much appreciate your time on a Friday afternoon. This is a further instalment in the series we've been running, having a conversation with you and very much wanting to be part of your treatment as the COVID-19 pandemic makes cancer care somewhat tricky. I'm Ian Irving, I'm Icon Group's Medical Director, and I'm very pleased to have with me today Associate Professor David Pryor, who is one of our senior radiation oncologists at Icon Cancer Centre, working out of Greenslopes and Redlands. David also works at Princess Alexandra Public Hospital, specialising in prostate cancer amongst other malignancies. So David, thank you very much for joining us today.
Thanks for having me.
It's a great pleasure to have you back, and it's a real privilege for us to have you working with us at Icon. I know I've worked with you for quite a long time now, David, and it's been
a long time ago.
It was
back in the Townsville days.
So it's fascinating to and fantastic to see your career reach these heights. The first thing I want to say to everyone, apart from of course having welcomed you, is to very much assure everyone that all of Icon Cancer Centres are open for business. So Icon are very proud to operate 30 cancer centres across all 6 Australian states. And during the COVID pandemic, and certainly as hopefully the COVID pandemic reaches the end of its course in Australia, Icon centres are very much open for treating people who need treatment for cancer care. And that assurance goes to our first question, where Bill asks, and thank you very much for your question, Bill, is it safe to visit an Icon Cancer Centre? What are Icon doing to protect me when I come for my radiation? And I think the short answer to that is we're doing a lot for you, Bill, for all of our patients and for our staff. But I'll throw to David to explain when you're attending for radiation, what things are Icon doing to make it practically safe for people?
Thanks, Ian. Yeah, well, one of the benefits of radiation therapy is that there's very limited opportunity for contact or exposure, and the cancer centres in general have got the advantage of being a fairly closed circuit or closed loop, whereby there's the opportunity for screening at the door, and that's not just screening of patients for symptoms or temperatures or potential contacts, but also the staff are regularly screened, and so there's a very low risk of exposure. And also with radiation, the time spent in the department is very short, so most treatments are over and done with 15, 20, 30 minutes, and within the department everyone's able to practice social distancing and good hygiene, so the risk of exposure during radiotherapy for something like this is very low, and we're constantly striving to keep that low. Obviously things were a little bit concerning early on when we didn't know how these things were going to ramp up, but we have always maintained that it should be healthcare as usual, and particularly now that things are under control and we're going to be dealing with this for a long time, it's very important to continue your healthcare as usual, because not treating your health problems or your cancer will likely pose a bigger problem to you than that very small risk now related to COVID-19, thankfully in this country.
And if you are part of the way through a course of radiation, David, it's important for that course to continue. You certainly wouldn't want people to be stopping and starting radiation therapy because of COVID-19 or other factors? No,
certainly not because of any fear of COVID-19, and there's even contingency plans for people who need their treatment to continue, even if they do contract COVID-19. So that all of these scenarios are planned for and factored in, but with community transmission so low, one of the big focuses is on making sure that people are having their treatment or are seeking attention for any health problems.
And following on from what you say about the importance of continuing to attend to your health issues, it was reported in the lay and medical media this week that PSA testing is down over 60% at pathology labs at the moment compared to this time last year. So it would seem that people, unfortunately, are putting off their normal healthcare needs, either due to COVID-19 or for other reasons. And Desmond asks in that vein, talks about that he worried about leaving the house and asking that exact question: is it better to put off my normal healthcare and attend to things such as PSA testing until the COVID-19 pandemic is finished? What would you say to Desmond and others who want to ask that question?
The short answer is no. You should continue your usual health care. Obviously, early on, when there was some uncertainty about how quickly was this ramping up, was it going to be another New York, for example, in Australia? That's just not been the case. And so, whilst a bit of common sense early on was fine, put things off for a few weeks. Now that we know that we're going to be dealing with this at a low level for a long time, it's time to get back to your usual healthcare. See your doctor for your routine checkups. It's not just cancer. There's stories of people not presenting with chest pain or not having their diabetes followed up. They're far greater risk than COVID-19 at the moment in this country. And so I would say, please see your doctor if you've got any new concerns, and still keep seeing your doctor for routine health checkups, and that includes everything.
Right, prostate cancer and general health concerns.
Yeah, if you're due a prostate cancer follow-up or another test, for example, at the pathology lab or at the X-ray department, for example, it's completely fine to keep doing that. Everyone's practicing good hygiene, good social distancing. They've all got good measures in place, and so please keep doing your usual healthcare.
Okay. Prostate cancers obviously a very common cancer. In fact, one of the commonest cancers, if not the commonest cancer in men. Do you want to run through for me and for the audience, David, what are the common symptoms of prostate cancer? When should someone seek medical attention, having now assured them that it is safe to seek such attention?
I think there's two components. So a lot of men might be diagnosed with prostate cancer without symptoms, and so it might have been after a discussion with their GP. They did a screening PSA test, for example. And so those discussions can continue happening. Other men might say have worsening waterworks. So even though it's a very common ailment in men as they get older, slowing of the stream, frequency, urgency, pain, stinging when they pee, maybe bleeding, any of those signs or symptoms, see your GP, get them checked out. New aches or pains, anything that's not normal for you, get it checked out.
Right, very good advice, thank you. So certainly don't ignore symptoms.
No.
And the symptoms, what you've described there, are quite wide-ranging, but important to follow up symptoms. And I think we can unfortunately say that over the years, men have certainly lagged behind women in following up their health concerns.
No, that's absolutely right. Blokes are very much of the "she'll be right, mate" mould, but no, see your doctor if something's different, something's not right.
And there are lots of reasons for doing that, but of course one of the absolute big reasons for seeking attention early is that cancer like prostate cancer is much better if you catch it early. There are presumably more treatment options. There are presumably better treatment options, David, if you catch it early. Do you want to just run through us in general terms, what are the spectrum of treatments that are used for prostate cancer?
Yeah, so in general, most cancers are better to be treated early. But for something like prostate cancer, where We also pick up a certain proportion of blokes very early with very, we call them indolent cancers, which may not cause a problem for them for decades. We've actually got a number of treatment options which range from closely watching it, so not treating straight away, all the way through to throwing the book at them, say with radiation and hormone therapy, even chemotherapy, for example. So there's a wide range of options for prostate cancer. And one of the keys, I guess, is, whilst there is some debate about the overall benefit of screening, if you know what you're dealing with, then you know the options, then if appropriately counselled, you can choose the one right for you. So say, for example, a bloke who's diagnosed with a very low risk prostate cancer. And what I mean by very low risk is there's a low risk that it will cause them any trouble, potentially over their lifetime. And there's a few key things that we look at when we define that, but in short, it's a good way to think about prostate cancer, whether it's a low risk in the long term or does it pose some risk. So for many low risk prostate cancers, in fact the majority of low risk prostate cancers now, we put on an active surveillance protocol. And so that means you're fit enough, you're healthy enough to have treatment if you need it, but at the moment you don't need it because it may not ever cause you trouble and you don't need to be exposed to the side effects. And so your urologist, for example, will have you on a program where they might do repeat biopsies, repeat scans, repeat PSAs, just to make sure that the cancer's not changing its spots and you've not gone on to a type of cancer that needs treatment. So that's very important, avoiding over-treatment, but you need to know what you've got before you can make that decision. And then as we move through the different types of prostate cancers, some prostate cancers have got a low risk of spreading, for example, but we still think that they might cause a trouble or problems or be a risk to you over the next decade or more. And so we're moving now more into the intermediate risk category. And for those blokes, there's options. So surgery, radiotherapy, even more these days as well, people looking at active surveillance for some early intermediate risk disease. And so the key there is to talk about your options with your family, with your GP, with your urologist and with a radiation oncologist. So options available, and it's about choosing the best one, the one that's right for you. And as we move further down the track, unfortunately there's some men who are diagnosed with high risk prostate cancer. So that's cancer there's a high risk that it could spread or has already spread, for example, and that's where we start to combine treatments. And so they might have a local therapy to try and cure what we know about, for example, or get rid of what we know about in the prostate, and that might be radiotherapy, for example, and we combine it with a drug treatment. So hormone therapy or anti-hormone therapy really is to try and get rid of the fuel for the prostate cancer and try and starve out the cells that might be floating around the body trying to find a place to grow. So as we move through, then the options change to more combining treatments and trying to incorporate specific types of drug treatments as well. So there's a wide range from watching it all the way through to throwing the book at it, so to speak. There's also, in terms of the weighting, there's also a separate type of watching, and we break it up into active surveillance, is if we're keeping a really close eye on it. Any change in the biopsy or the PSA, we might think about converting to treatment, but there's also a different strategy of watching, and it's something that we commonly employ in men who are older, or men who don't have a long life expectancy because of other illnesses, for example, and that's called watchful waiting. So that's saying, hey, you've got a cancer, but it is unlikely to cause you problems over your lifetime. You've got a lot of other things on your plate that'll probably cause you problems, so let's just wait and see if this causes you a problem, and if it does, we'll treat it then. So that's watchful waiting, which is very different to active surveillance, which is at the first sign of it becoming a cancer that could cause you trouble over 10, 20 years, then we'll look at treating.
So, and that's very well explained. Thank you, David. So the active surveillance and watchful waiting are quite different, but certainly both of those strategies, active surveillance and watchful waiting, are not doing nothing, are they? They're not forgetting about things. They're not putting your head in the sand. They're not being defeatist. They're two different strategies of observing the situation, and with active surveillance, as you point out, it will involve repeated tests and repeated visits with the urologists and all of the treating doctors being very careful to jump into treatment when necessary.
Yeah, and that's why the terms are very carefully chosen. They're not perfect, but watchful and active. It's active care, but it might be in that bloke's best interest to not receive those particular treatments, but the care is still very much active.
As a ballpark figure, what percentage of patients generally fall into being able to have active surveillance as opposed to requiring treatment, David?
So the majority of low-risk prostate cancer, which I don't have the figures immediately to hand, but that might be a quarter or a third of diagnoses perhaps. The majority of low-risk prostate cancer patients will be suitable for active surveillance, and so I think depending on the jurisdiction, it's up to about 80% of low-risk prostate cancer patients may start on some form of active surveillance protocol, and then it may be that a proportion of them have to move on to having active treatment, but no, the majority of low-risk prostate cancer patients would at least initially be suitable, so it's something that's always discussed with them. And then at the other end of the spectrum, there's not too many blokes in their 80s getting treatment for prostate cancer, for example. If they happen to be diagnosed without symptoms, the majority of those blokes may well go on to a watchful waiting strategy. But again, there's some forms of prostate cancer that can cause problems within a few years in the very high risk category, and there's some 80-year-olds who are incredibly fit and potentially more likely than us to get through 10, 20 years, so it's all individualised.
Sure. No, thank you. Now, if someone does need treatment, you mentioned the various treatments around hormonal therapy, radiation therapy and surgery. Let's just hone in on radiation for a minute. We had a couple of questions come in about wanting to know the difference between brachytherapy and external beam radiotherapy. There's also, of course, radiation is full of lots of technical terms and jargon and words like hypofractionation and length of treatment. So could you run through us, David, explain some of these technical terms and tell us what does radiation therapy involve for prostate cancer?
Again, it depends. So say, for example, if you've got a new diagnosis of prostate cancer, you're going through your treatment options and you wanting to explore radiotherapy as an option. So within radiotherapy, there's a couple of different ways of giving it. And so one's called external beam radiotherapy, and that means that you're on a machine called a linear accelerator. So again, you're lying down on a couch similar to a CT scan, and then the machine whizzes around you and delivers the radiation from the outside in. A second way of delivering it is called brachytherapy, and that's where we insert either radioactive seeds or you have needles implanted that have a radioactive source going out, and that creates radiation intensely from the inside out, but over a very short distance. So in general, for the earlier stage prostate cancer, it's an option to have external beam or brachytherapy, and it's commonly the seed brachytherapy. And the only things that would perhaps steer blokes away from brachytherapy are blokes who have very large prostates where it's difficult to get the right placement of the seeds, for example, or if they've needed a rebore, so a TURP in recent history. And there's a few other technical factors as well. As the prostate cancer, the risk of the prostate cancer spreading outside the prostate grows, then there's a higher risk that the very focal brachytherapy may miss some of those cells that are just outside. So that's when you're getting into the higher or more unfavourable or high risk territory. That's when we start looking at using external beam radiotherapy solely, or you could potentially do what we call a brachytherapy boost. And again, that depends on a few different things. So that's the different ways that we can use radiotherapy, and sometimes the different ways that we think about, one or the other, or combining both. Overall, if it's, say, brachytherapy, there's generally two day procedures, a planning procedure and an implant procedure. For external beam radiotherapy, you also generally have a planning procedure, and that's the external beam radiotherapy. There's no needles, it's non-invasive, and that planning procedure happens over about an hour or two, again using a CT scanner. And then when you come back for treatment, and it might be a week or two later, for example, when you come back for treatment, you tend to come into the department for 15-30 minutes each day. The treatment themselves are fairly quick. You don't feel anything. If it's external beam radiotherapy, you're not radioactive, and it doesn't knock you around in the short term while you're receiving treatment. In fact, most blokes who are having radiotherapy can continue to do most of the day-to-day activities without interruption, aside from feeling a bit more tired. As the treatment wears on, they can start to notice some issues with their bladder and bowel, so they might pee a bit more frequently or slowly, might sting when they pee, for example, or their bowels might be a bit looser or a bit more urgent. But on the whole, it's a very well tolerated procedure. One of the other things, though, is that as technology's improved, we've been able to limit the amount of the rectum and the bladder that gets that same dose, and so the side effect profile has been reducing year after year as the technology's improved. Our understanding of the biology of prostate cancer has also improved, and so it used to be that most of our treatments went over 8 weeks, for example, whereas now we've got good data that the majority of blokes receiving prostate cancer radiotherapy for a new diagnosis can have treatment over 4 weeks. And increasingly, we're also using protocols incorporating a thing called stereotactic radiotherapy, which is a type of external beam radiotherapy, where we can deliver the treatment in as little as 5 sessions. And so there's a big range, and again, it depends on your discussion with the radiation oncologist as to what's the best option for you. I guess one other thing that blokes might ask about is after surgery. So occasionally after surgery, we also use radiation therapy. The PSA can start to rise, and there's evidence that the cancer's returned. So it's not uncommon that we give a radiotherapy after surgery, and in those instances, we do tend to take it a bit slower still. Most treatments for that indication are still over 6 or 7 weeks, and that's because we tend to need to treat a slightly larger volume of the bladder and the rectum, because the prostate's no longer there. So we're treating where the prostate used to be, and part of the bladder now is. So those treatments we're still doing over 6 or 7 weeks. But when we're treating the prostate, whilst it's still there, so there's not been surgery, we're treating the prostate up front. The treatment protocols are progressively getting shorter and shorter as technology and our understanding improves.
Which is a great thing. When you mention 5 weeks of radiation for prostate cancer, or 8 weeks, David, I take it that involves coming to the centre once per day,
yes,
and that each time you attend a centre, we call that a fraction. So if you're coming for 8 weeks, Monday to Friday, which is 5 days a week, that would be 40 fractions. Have I?
Yeah.
We've got the maths right.
That's right. So hopefully not too many people getting 40 treatments for prostate cancer these days, but it's sometimes required. But yeah, it's once a day, Monday to Friday.
Right.
And as I said, the treatments these days, the machines have really got it down to most people only needing to be lying down on the couch for 10, 15 minutes.
And why don't we treat on Saturday and Sunday?
It's an interesting question. So for prostate cancer, it doesn't actually matter. So whether we deliver the dose over 8 weeks or 4 weeks, it doesn't matter. It's not the type of cancer that's going to grow rapidly on a weekend, for example. But traditionally, that got embedded from treating head and neck cancers, where they did do studies where they said, look, if you shorten the treatment, treat 6 days a week, you'd get slightly better outcomes. But then a Polish group said, what about 7 days a week? And they actually got too much toxicity. And so it does actually work out that treating 5 or 6 days a week with a little bit of extra time for recovery in between time for some of those intensive treatments like head and neck cancer treatments is actually the best way of doing it. For prostate cancer, it doesn't actually matter. So say, for example, there's a recent study came out from the Sunnybrook group that looked at this stereotactic radiotherapy and said it doesn't matter if we give it over a week, once every day or once a week. And short answer is it doesn't matter for prostate cancer.
Reassuring to know. Now, you touched on side effects of radiation and particularly mentioning that there aren't a lot of side effects and that men could continue normal activities. I assume that means including doing the dishes and doing some housework.
That's right.
It's not an excuse to say you're having radiation, that you can't wash the dishes.
No.
Okay. What sort of side effects occasionally do people get with radiation?
So as I said, some mild fatigue during treatment, and then most of them are to do with the bladder and bowel being irritated during treatment. So maybe a quarter of blokes get some mild bother during treatment. A few percent might get significantly bothersome frequency, urgency, or slowing of stream. It's pretty rare for the stream to slow right down, for example, and they can't pee. But most of that settles down. So when we're looking at the doses of radiotherapy we use, the main thing we're looking at is that with that long lens. So we're not so much worried about guys getting through treatment. Most guys get through treatment fine. We more try and tailor the dose based on what's your risk over 5, 10 years down the track of getting a significantly bothersome side effect like bleeding from the backside or waterworks or incontinence or something like that. So that's what we're really focused on, is not so much worried about the short term, because most blokes get through it. It's how can we reduce those long-term risks. And again, that's where the improvement in technologies has really reduced that. And there's other things that have come onto the market, like space or hydrogel, for example, which we can insert in between the prostate to push the rectum away from the high dose region, so that can reduce the risk of late rectal bleeding. The waterworks, again, we're keeping an eye on in conjunction with the urologist, your flow, urgency, frequency, those sort of things, what their capacities in the long term. And then other things like erectile function tends not to have an immediate hit with the radiotherapy, but it can with time accelerate the usual age-related decline. So radiotherapy generally has an advantage early on for erectile function, but by the time you're 5, 10 years down the track, it can certainly have an impact, and most blokes are around the same level. And finally, one thing that blokes often worried about is, doesn't radiation cause second cancers, for example? They might have heard things like that from the web or from friends, but the reality is that a second cancer from the radiotherapy itself is actually very low risk. For most blokes, it's going to be 1 in 10,000 or thereabouts over their lifetime. And a lot of the studies that looked at that, those sort of risks, where they've done a proper comparison of no radiation versus radiation in a randomized fashion, there's not been a huge difference. It's not been a detectable difference, should I say, over a decade. And so we know it's there, but it's a very low risk. So we factor that into our discussions, but compared to the current cancer that they've got, it's generally a very small consideration.
No, very comforting to know. Thank you. Just to finish off in the last minute or two to address some live questions that have come in, and again, on behalf of the whole ICON group, we very much thank you for tuning in. We thank you for giving up small time on Friday afternoon to watch the segment. But we've had some questions come in about the treatment of prostate cancer and how difficult it is once it's already spread. So if it's spread, say, to the lungs or to bones or other organs, how is treatment for prostate cancer done then, David?
So when it's spread to bones or for example, lungs, then the cornerstone of treatment is generally the drug treatments. So the hormone therapies, the chemotherapies, for example. When a prostate cancer is just in the bones, And it's similar to breast cancer. If it's bone dominant, men can still live for many, many years with a good quality of life. When it spreads to the lungs or the liver, that's generally a sign that it's a more aggressive version and that you're more likely to have to cycle through chemotherapy drugs sooner. And so it's associated with a quicker progression, but there's still treatment options, and a lot of it can still depend on the underlying biology of the cancer. In terms of radiation therapy, we've usually not used it for people with metastases to the lung in prostate cancer, but the more and more we're using these new imaging modalities, we are getting the occasional patient through who's a long distance from their initial treatment, and they've just got one spot in the lung that's biopsy proven it's prostate cancer, but it's nowhere else. And so for a very small minority of men with this, so they call it oligometastases, we're seeing a very small proportion where it might be in the lungs or the liver. And the question is, yes, instead, as well as this, the chemotherapy, the hormone therapy, is there a benefit to getting rid of what we know? We don't know the answer, but it's something that's being explored. Right.
No, thank you. Our final question for the day goes to Carmen, and we thank you if you're watching, Carmen, for your question. Carmen points out to us that, of course, women have not been getting as sick from COVID-19 as men, and I can see a lot of sort of nodding in the room that just proves all along that women are stronger than men. But she asked the question, and it would be fascinating if you could answer this, David, but it might not have an answer, in that to help with COVID-19, should people be using anti-androgens and have anti-hormones to potentially protect them from COVID-19? Have you?
No. So there has been a lot of talk in the scientific community about what drives this disparity between men and women, and there is some preclinical data about expression of various enzymes and the androgen dependence of it. So there is actual scientific discourse going on about, is it protective to have low testosterone? But no, there's no direct evidence that it's of benefit. We certainly wouldn't recommend it, Donald Trump style, to cure COVID-19 for men out there. But equally, I also reassure blokes going on to hormone therapy that there's certainly no indication that they'll be worse off. So no, it is very interesting. It's something that's being looked at. I don't have the answer, but it's certainly no reason not to go on it. But we don't put anyone on it who doesn't need to. It's not very pleasant. Yeah. If you don't need it.
That's a very good point. We thank you for that. And COVID-19, of course, has only been upon us for a number of months, and there's a lot that we in the medical community and the medical community around the world, of course, are still learning about this illness. And so I think the way David explains that is very appropriate and very honest, that yes, there's been observations that women are not suffering as much severe COVID-19 as men, but the exact scientific explanation for that is not known, and the theory put forward around hormones is very valid and very interesting, but certainly not proven at the moment. And so acting on things that aren't proven absolutely should be discouraged, as David has mentioned. That brings us to the end of our session. Once again, I very much want to thank David, Associate Professor David Pry from Princess Alexandra Hospital and Icon Cancer Centres at Redlands and Greenslopes, for giving up his time. I think it's been a fantastic session, not just on COVID-19, but on prostate cancer in general. So once again, thank you, David, for coming along. And thank you, everyone, for watching. I very much hope you have a good weekend. Stay safe for the remainder of the COVID-19 pandemic. As David said at the start, please keep attending to your general health matters. Visit your general practitioner. Establish a good relationship with your general practitioner. It's absolutely vital. both in these times with COVID-19, but also in all times. So with that, I wish you a good weekend, and once again, on behalf of Icon Group, thank you very much for watching.